be here this evening to present this topic. I have to make a confession. I don't think I'm the absolute expert on this topic. I know many of you, the audience, healthcare providers, especially frontline clinicians, you have seen more COVID-19 patients that I have seen. So of course you may have your insight, and that's why I would like to make this a two-way conversation, and we would have really appreciate to have your feedback, even if you have a different insight, to share it with us as a question or as a comment. And again, it's really my pleasure to be here with you and present this interesting piece. So I have no disclosures, and these are my learning objectives for this session. So we all know with the COVID-19 pandemic and how it started in 2019 and expanded over the past 2 years with millions and millions of affected people in all the different continents. We can see the statistics looking at the infected populations from 2019 up to 2020 in the different continents. Which actually made it, according to the WHO, as the fourth leading cause of death in 2020. So when we think about the COVID-19 and how it's associated with thrombosis, it's very important to look first at the pathophysiology of the COVID-19 infection and how SARS-CoV-2 infect the airway cells. So we now have a very good understanding that with the SARS-CoV-2 having the spike protein, they cleave the ACE2 receptor and they bind through that site to the airway host cells, which leads later on to the endocytosis of the viral material, which leads to the infection of the lung. And that is followed, of course, by infection of pneumocytes, as well as vascular cells, which lead to a myriad or a sequence of inflammation and immune-mediated reactions. The T lymphocytes, monocytes, neutrophils, and macrophage are all recruited, which lead to release of a lot of inflammatory mediators, as we can see here, a process that is now known as a cytokine storm. This by itself leads later on to vascular damage as well as platelet activation, which could lead to the formation of microthrombus inside the lung and in the vasculature of the lung, which can later on progress into venous thromboembolism, as well as either as a DVT or as PE, which is pulmonary embolism. And of course, if we think about the Virchow's triad, which actually cornerstone that we rely on when we think about risk of coagulation in any population, we see that in the COVID-19 patients also, they do have a lot of these risks. So if we think about circulatory stasis, we know that those patients are prone to have prolonged hospital stay and immobility, which definitely is very important risk factor. In addition to that, also we do have hypercoagulable state due to the cytokine storm that we talked about and all these inflammatory mediators, which also lead to endothelial injury because of that inflammation process. So all of that have been shown to increase the risk of venous thromboembolism as well as arterial thromboembolism in the form of myocardial infarction sometimes, or disseminated intravascular coagulation. To the extent that, especially at the beginning of the pandemic, it has been estimated in some studies that VTE events in COVID-19 population that are hospitalized may reach up to 25%, and that incidence in ICU patient may reach almost up to 50%. And even post-mortem data have shown that many of the fatalities has been because of PE events. So in order just to kind of like make sure that we're all on the same page, there are some important terms that we want to be all familiar with. So the first one, of course, that we just mentioned quickly is the disseminated intravascular coagulation, or the DIC. So this is basically a process where we have uncontrolled clot formation that leads to loss of balance between the pro-coagulation factors and the anti-coagulation factors. At the end of the day, this will lead to fibrinolysis and multiple organ dysfunction and could lead to either thrombosis or hemorrhage, depending on which factors are depleted first. Of course, there are some important clinical signs of overt or complicated DIC, and those include thrombocytopenia, prolonged prothrombin time, elevation in the D-dimer, and increase in the fibrin degradation product. And there is a very nice tool that we rely on to calculate the DIC score produced by the ISTH organization, and we're going to share that in the next slide. Also, there is another term that is important, which is the sepsis-induced coagulation, or SIC. And this is basically disseminated intravascular coagulation that is complicated by infection and sepsis. And we do see that, of course, with the COVID-19 infection. And with the SIC, it has a little bit of a different scoring that takes also into the account the process of the sepsis through the SOFA score. So over here, we do see how the ISTH developed the scoring system, which relies on the INR or the PT time, fibrinogen levels, the D-dimer levels, and the platelet, and gives points from 0 point up to 3 points, as we can see on that table. And of course, patients that have score of 5 or more are considered to be positive for overt DIC. Less than 5 is considered to be negative, but patient could still be at risk of uncomplicated DIC. So in summary, and through the past few slides, we now understand that with the SARS-CoV-2 infection, we do have, of course, a pro-inflammatory state as well as a pro-thrombotic state, all of which lead to increase in the release of these mediators that are highlighted in the blue boxes. So in terms of the myocardium, sometimes we do see elevation in the cardiac enzymes, like the troponin, as well as with the pro-inflammatory state, we do see increase in the interleukin-6 as well as the CRP. And then with the prothrombotic state, whether it's the DIC or SIC, we do see elevation D-dimer, prolongation of the PT, again, increase in the fibrin degradation products, and thrombocytopenia. So now I would like to kind of, just make sure that we're all on the same page, audience and speakers, and have this question. The question states, which of the following lab findings might be present among hospitalized patients who are diagnosed with COVID-19? So we have answer A, low D-dimer levels, high platelet counts. Answer C is high CRP levels, and answer D is high fibrinogen levels.
So I will open the poll for the audience to answer the question.
Sure.
Okay, so I can see now okay. Majority are answering the question in progress. Okay, so we have 9 seconds remaining, 5 seconds. Okay. So the correct answer is CRP. Okay.
So that's the high CRP levels.
CRP level, yeah. I'm just waiting for the poll to release
the. Okay.
Yeah. It's okay. Yeah, it's ready, I guess. Okay. Can you see the poll answer? Yeah. So I can't see actually.
I don't, but that's okay. If we have statistics, you can mention it, Dr. Mona. If not, then we can proceed. Oh, okay. I see it now.
You see it? Okay.
Yeah. So I think for those who answered, we had many that didn't really answer, but for those who answered, we have the answer C, they answered correctly. So that's absolutely right. So definitely, as we have explained, the CRP level with the cytokine storm is one of those mediators that we see elevated most of the time in COVID patients. Actually, D-dimer would be elevated and the platelet count would be probably low as a thrombocytopenia, and the fibrinogen level maybe also would be low. Okay, so now let's move to the following question. So over here, we have the question states, what is the SIC score? SIC, again, is the sepsis-induced coagulation score based on the ISTH criteria, which is mentioned over here. For a 45-year-old COVID patient that has these vital signs, and the D-dimer is 5.4, the platelet count is 60,000, INR is 1.4, and SOFA score of 1.
Okay, I will just give them some time to think about the question. And we have comment on the previous question. I can address it after this. So I think the comment is that until the audience can calculate the score, the comment is that they are saying majority of the cases and COVID, they have high fibrinogen level, not low.
Oh, okay.
Okay.
That's interesting.
Yes. So, okay. So let me just share the open the poll for audience to answer. Okay, so I think now you can start recording your answers. So we have 5 seconds remaining. So I think the correct answer is 5. Okay. I think you can see.
It's, apologies, me, Dr. Mona, you had like the previous version of the question. So actually,
Okay.
for this, I apologize. So yeah, the correct answer is D again. So
Okay.
I changed this question. So yeah, the correct answer is 4. So again, and maybe we can just calculate this quickly together. So according to this calculator, we have over here an INR of 1.4. So we have 1 point. The platelet count is actually less than 100,000, so we have 2 points. And then the SOFA score is 1, so we have 1 point. So the total is 4 points, which actually positive for SIC. So do we have any other questions so far, other than this comment, which I may, kind of like discuss with that person towards the end of the presentation?
The person saying that it's part of the inflammatory reaction typically seen in hospital in sepsis and in particular in COVID patients.
Okay. Apologies if that was a mistake from my side. Again, I would be happy to review that piece of information. And that's why I said I'm not the most knowledgeable on that topic. I'll be glad to get feedback, no offense. All right. Okay, so moving now, let's go ahead and start the case. And I would like just to use this case and another case throughout the remaining of the presentation. So we have over here a 49-year-old man admitted after 5 days of fever, progressive shortness of breath. The patient is obese with diabetes type 2 on insulin, and he has also stage 2 CKD. The AD, these are the vitals. We have heart rate of 98, blood pressure 134/88, and the respiratory rate of 24. The oxygen saturation is 84, and with 2 liters of oxygen is 94%. No leg swelling. The dimer is elevated, 8.4. The chest X-ray show bilateral patchy infiltrates, and with the CT scan on the chest, no PE. However, we have the typical bilateral ground glass opacities and consolidation that we see with COVID patients. Patient is to be admitted to the general medicine ward. So now this is the impression after and the plan after being admitted to the medicine service. Started on 2 liter of oxygen. We have elevation in the D dimer, and again, CT scan shows negative for the PE. So the questions that really are important for us now is, what is the VTE risk for this patient, or at least is it high or low? And what VTE prophylaxis would you use? So again, remember we talked about the VTE risks that are some important risk factors just for this patient being a COVID patient, but also um, uh, looking at his demographics as well as some of the diagnostics. We do see elevation in the D dimer, which I will touch base on quickly. The D dimer, of course, is indication of high risk for VTE. And in addition to that, this patient is obese and with diabetes and CKD. All of these comorbidities, again, increase the risk for VTE. So I would say this patient is at high risk for VTE. And now looking again in few slides at what could be or should be the VTE prophylaxis that we would use in this patient will answer that. So again, the D dimer, it's very important to know what D dimer is, because it will be presented in many of the clinical trials that we will discuss today. So the D dimer, of course, is a marker of the cross-linked fibrin formation and breakdown. It has a very high negative predictive value for VTE, meaning that whenever we have a low D dimer, this gives us indication that we do not have a VTE. So it gives you a really good negative predictive value. However, if it's high, it doesn't necessarily mean that this patient has a DVT or PE. So it's not really a specific marker. It could be elevated in so many other conditions and processes in our body. And in COVID-19, it has been shown actually that there is an elevation in D dimer in a lot of patients, and that could be used as a risk factor and surrogate marker for incidence of VTE in those patients, even for post-discharge, as well as the severity of the case and mortality. And this has been shown in multiple small studies showing, comparing, for example, ICU versus non-ICU, and showing that D dimer is typically associated with ICU admission, as well as mortality and complication of COVID cases. So when we talk about the VTE prophylaxis, so again, we understand now that there is an increased risk of VTE in the COVID-19. Thromboprophylaxis is typically indicated in all hospitalized patients. However, we do have to consider the bleeding risk. And the problem is not just that we need thromboprophylaxis in VTE in COVID patients. The problem is, which agent should we use? Which dose should we use? This was the question that was kind of puzzling many clinicians, especially at the beginning of the pandemic, because what has been shown is that even when we use the typical prophylactic dose of anticoagulant, those patients still sometimes develop VTE events and sometimes may die from PE and from thromboembolic events. So this have triggered many clinicians and many scientists to start some clinical trials to try to answer whether should we give those patients just prophylactic dose, or should we give them an intermediate dose somewhere between the therapeutic anticoagulant dose and the prophylactic dose. So these are the questions basically that we are going to try to find out an answer for, especially that over the past, I would say 3 months, we have been hammered by many of the results from these trials. So many of the trials that I'll be presenting today are really very recently published. So in general, when we think about VTE prophylactic alternatives, we know, of course, that the gold standard is the heparin, whether as unfractionated heparin, which is now not the best agent that we use. Most of the time, we use the low molecular weight heparin, especially enoxaparin, that is available in majority of the hospital, and 40 milligrams sub-Q daily. This is the standard dose that is used, which may be lowered to 30 milligram if patient has creatinine clearance between 15 and 30 mL per minute. Unfractionated heparin is preferred when we have patients with acute renal failure or advanced CKD, and the dose is 5,000 units subcutaneous, could be every 8 or 12 hours. Also, the DOACs have been shown to may have a role as prophylactic agents in VTE, although they do not have FDA approval or other agencies' approval to be used in medical or medically ill patients as a VTE prophylactic agents. But we do have studies that support the usefulness and the efficacy of these agents, especially for the apixaban as well as the rivaroxaban through the ADOPT study and the Magellan study. So now that we know the different agents that could be used in the VTE prophylactic, let's go together and try to answer the first question. So do we have an evidence regarding which agent should be used in COVID stable hospitalized patients, whether we should be using the typical prophylactic dose, intermediate dose, or therapeutic dose of anticoagulant? The first study that tried to answer that question is the ACTION trial, and this trial was published this year, a few months back in the Lancet journal. And the question that we're trying to answer here is whether therapeutic prophylactic anticoagulation with the rivaroxaban is better than the prophylactic dose that is standard dose that we use in non-critically ill COVID-19. The population in this study were 615 hospitalized patients with elevated D-dimer in Brazil, 31 Brazilian sites in the year of 2020 up to early 2021. And the intervention they used, again, is the rivaroxaban therapeutic dose, which is a 20 milligram that could be lowered to 15 milligram if patient have low creatinine clearance for 30 days. And the comparator is basically the prophylactic dose of enoxaparin or unfractionated heparin while the patient is in hospital. And again, extended prophylaxis may be done at the discretion of the healthcare provider. The outcome is looking at the composite of time to death, duration of hospitalization, or duration of oxygen need. And this was open label RCT for 30 days. So if we look quickly just at the baseline characteristics, and I will not go through everything, but just to highlight some important points, we see over here that, again, the majority of those patients had stable condition. So we can see almost 95% of them had stable clinical condition, again, confirming that these are non-ICU criteria of COVID patient. And again, over here also, we want to highlight that maybe about 75% of those patients required oxygen support. Most of that was through just oxygen mask, but very few of them needed intubation or non-invasive ventilation. And the D-dimer concentration, we said that one of the inclusion criteria was elevation of the D-dimer. So we do see that they used more than one time the upper limit of normal as the inclusion criteria. And we still see some of them that even have higher D-dimer level, more than 3 times the upper limit of the normal was found in almost quarter of that population participating in the study. Unfortunately, this study did not show any difference in the efficacy outcome, which again was the composite outcome of death, duration of hospitalization, and duration of oxygenation over 30 days. So we can see over here the therapeutic anticoagulation in the orange bar compared to the prophylactic anticoagulation, almost no difference. And the win ratio, which was kind of similar to the odds ratio, but this is the type of Bayesian statistics that was used in this trial. So it shows what we call win ratio. It was 0.86, and again, that was not statistically significant. And this again is confirmed over here on the Kaplan-Meier curve, showing there was no difference between both arms in the efficacy outcomes. Also, when they looked at the different individual outcomes, whether death by itself or hospitalization duration or duration of supplemental oxygen use, again, there were no difference between both arms. On the other hand, we do see that there was an increase in the risk of the bleeding with the therapeutic anticoagulation, so almost 3-fold increase in the risk of the bleeding, major or clinically relevant non-major bleeding according to the ISDH definition. So this was the first trial. The second trial that also tried to answer that question is basically a multi-platform RCT. It's a combination of 3 different trials that pooled their data together. The first one is called the ATTACK trial, and the REMAP-CAP, and the ACTIVE-4A trial. So again, this trial over here was again trying to answer the same question, looking at the therapeutic anticoagulation compared to usual care in non-critically ill patients. There were a bigger sample size, more than 2,000 patients, and so many clinical sites around the world, 129 hospitalized sites. They were without any need for ICU level care of oxygen or mechanical ventilation, vasopressors or inotropes within the 72-hour of the admission. The intervention was different. So over here, they used therapeutic anticoagulation with low molecular weight, or heparin, which was very few patients. And the comparator was typically the usual care with the low dose of anticoagulants, and maybe about 26.5 for them were on intermediate dose anticoagulation. The outcome was, again, slightly different than the first trial. Over here, they looked at what we call organ support-free days. So this is just looking at the number of days that the patient spent in the hospital without any need for organ support. Death was considered to be given a score of -1. So this is the worst score that you can ever get. And as that number go up, that means that you have better outcome up to the number of days of this trial, which was 21 days. So actually the maximum score was 21. So from -1 to 21, 21 being the best and -1 being unfortunately dead. This is an RCT open label, and again, combining 3 multi-platform RCT. When we look at the results from this trial, we do see that the odds ratio show an improvement in the organ support-free days in the therapeutic dose anticoagulation compared to the standard thromboprophylaxis. Almost 27% increase in the organ support-free days. And again, when we look also at how that looked like across the D-dimer levels, we do see that with the high level D-dimer, there was a little bit better outcome, but again, these outcomes persisted or was closer to be the same in the low level as well as those patients that had unknown level of D-dimer. So again, showing an improvement with using therapeutic dose anticoagulation, with a little bit better outcome in the high D-dimer level, but again, the outcome almost persisted in all the patient population that were included. And this graph is showing us, again, the same results. So the blue line means that we have more organ-free support days. So as you can see, more blue with the therapeutic dose compared to the usual care thromboprophylaxis. Again, when they looked at the secondary outcomes, they also found that we do have improvement in the survival without organ support at 28 days, also 30% improvement in that outcome, as well as with the improvement in the thrombotic events or death. There was a reduction of about 28% in these outcomes, favoring the therapeutic dose anticoagulation. And of course, there was still an increase in the risk of the bleeding. Almost the odds ratio here is 1.8, so almost 80% increase in the risk of bleeding. That was not statistically significant, however, but there is definitely a tendency there. So based on these 2 trials, I have, again, a couple of questions for you just to make sure that the audience is following with us. So I will read the first one. Based on the results from ACTION trial, the first trial we presented, the use of therapeutic dose of levodopa 20 milligram every day, it is associated with increased risk of bleeding, reduced risk of hospital stay, reduced risk of VTE, no effect on VTE or bleeding events.
Okay, so I will open the poll for the audience to share their answers. Okay, I can see majority are answering the question. Okay, so we have less than 5 seconds remaining. So I can see, okay. So the correct answer is, I think A, increasing the risk of bleeding.
Exactly. So that's definitely the correct answer. Let's, I'm not really sure if I can even.
Yeah, just I'm waiting the WebEx to generate the, okay. Can you see the, answers.
So
You
yeah,
can see that.
for majority of those who answered, again, they answered the correct answer A, which increased risk of bleeding. And this is, as we have shown, that was the result from the ACTION trial with the use of the rivaroxaban, and there was no effect on VTE or the hospital stay. So now I have also another question. The multi-platform trial that studied the therapeutic dose, we can give it the acronym TD just to make it easy, with low molecular weight heparin compared to the thromboprophylactic dose PD in stable hospitalized COVID patients. It has indicated that A, no difference between the therapeutic dose and prophylactic dose in efficacy or safety outcomes. The therapeutic dose improved support-free days compared to the prophylactic dose. The therapeutic dose reduced the incidence of VTE mortality compared to prophylactic dose. Therapeutic dose improvement compared to PD was only in the high D dimer level patients. The answer B and C, both are correct.
Okay, so I will open the poll now, so you can share your answers. Okay. Oh, I can see. Okay, we have less than 5 seconds remaining. Okay, maybe halfway through. Okay, so you can share with us the correct answer, Dr. Hazem, until we have the result generated.
Sure. So again, if you recall, the results have showed both there is an improvement in the support-free days, as well as that there is the reduction in the incidence of the VTE as well as the bleeding. So definitely the correct answer is E, as answered by majority of you. So that's the correct answer there. And again, with regards to the D dimer level, although there was a bit of better improvement in the high D dimer level patients, but the improvement persisted in majority of the patients. All right, so let's continue with our case. So on hospital day 4, the oxygen requirement for this patient rapidly increased to 6 liters. He was transferred to ICU for high flow oxygen, and he started to develop organ dysfunction, acute on chronic renal insufficiency, with creatinine clearance being now less than 30 mL per minute. The question that comes up: do you change his VTE prophylaxis regimen? So yes,
Dr. Hazem, maybe before you proceed, maybe we can ask the audience just to type in the chat if their answer is yes to this question.
Sure.
Yeah. So what do you think? Do you think would you change the VTE prophylaxis regimen in this case? You can just type yes or no in the chat.
So in order to just kind of make it easy again, if we consider that based on the results from the first set of trials, that we're going to start our patient on low molecular weight heparin, enoxaparin, 40 milligrams, sub-Q daily, or or therapeutic. I think therapeutic would be the best choice in that situation. So therapeutic would be 1 milligram per kilogram. So if we think that this patient is 80 kilogram, let's say, we're starting this patient on 80 milligrams subcutaneous twice daily. Would you change that now, given the current circumstances of being transferred to ICU, as well as the acute on chronic renal insufficiency?
Okay, so I can see majority of answers yes. Yes to heparin because of AKI.
Yeah.
The patient should have had the therapeutic low molecular weight heparin from start. Dalteparin is as a preference. Yes, yes. So the majority said yes.
Okay, great. I think the audience that we have is really good with this topic, so that's exactly what I would go with. So if we keep moving, let's see what the evidence is saying regarding that piece of topic. So now we have patient that is in COVID ICU. And again, over here, we want to differentiate between two things. Well, it's completely different according to many expert opinions. And again, you clinicians among you who have been, facing COVID patients, maybe also would be helping to comment on that part. Whether the patient has been admitted directly to the ICU is completely different picture than patients that have been hospitalized, being medically ill on the medical ward, and then they have been started on anticoagulant, and then they were transferred to ICU. So according to many of the expert opinions, it would be when you treat those that have been admitted directly to the ICU, these trials that I'm going to show you right now this is what it is about. But if you have a patient that has been already hospitalized on the medical ward and you started them on therapeutic dose, then you would probably continue this patient on therapeutic dose because I think the right thing to do, and this is not what the trials that I'm going to show you was trying to answer. So that I think as we go, we can discuss this further, but you will understand exactly what I mean after I show you the evidence here. So these next set of trials basically were trying to answer the same question, but in ICU patients. So we have the first trial, the Inspiration trial. This was a trial published in JAMA, and this was done primarily in Iran, that recruited 600 patients and compared between intermediate anticoagulation with prophylactic dose. So the intermediate anticoagulation that they used was enoxaparin 1 milligram per kilogram once daily, and the prophylactic dose, of course, was enoxaparin 40 or unfractionated heparin 5,000 units. The outcomes that they looked at was the composite of acute VTE, arterial thrombosis, treatment with ECMO or all-cause mortality within 30 days. And this was a 2x2 factorial design trial that looked at two factors. The first one is basically comparing intermediate versus standard prophylactic anticoagulation. And the second factor was comparing statin therapy versus placebo. And of course, we're focusing here on the anticoagulation part. So in fact, this trial have shown that intermediate dose does not differ at all to the standard dose of enoxaparin. The hazard ratio is almost 1, not statistically significant. So no benefit from using intermediate dose enoxaparin compared to the standard dose. And in fact, even when we look at all the other secondary outcomes, we see that there were no difference in all these outcomes. Even when we look at the bleeding, we do found that there was tendency, again, towards an increase in risk of bleeding, but that also was not statistically significant. So mostly negative results from this trial. The second trial was actually the same one that we have discussed earlier, but this one was focused on the population that were critically ill. So those were that meet the criteria of ICU admission, if you will. And again, these were the three RCTs combined together into that multi-platform RCT. So the criteria that they put to be critically ill was basically requiring high flow nasal oxygen, mechanical ventilation, ECMO, or requiring vasopressor or inotrope support. And again, the randomization to therapeutic anticoagulation or usual care. And the results that they found from this trial was that the median organ support free was almost the same in both arms. 3 days with therapeutic anticoagulation and 5 days with the usual care. And again, the odds ratio were not statistically significant. So no difference between both arms in terms of the efficacy. The major bleeding was higher with the therapeutic anticoagulation as expected compared to the usual care. But again, that was not statistically significant. So in conclusion, what we found out, and again, this was kind of almost the same trial, but done on a separate population that require immediate ICU level care at the time that they were recruited for the trial. So for those folks, for these kind of patients, therapeutic anticoagulation did not improve hospital survival or days of free organ support compared to the usual care pharmacologic thromboprophylaxis. So again, this was a little bit bizarre to many clinicians that you would expect that more benefit would be happening with the ICU patients than the medical ill patients. However, that was not the case. Therapeutic anticoagulation did not really improve those patients. Now, the last piece that I would like to present you in this aspect is the HAP-COVID randomized clinical trial, which was published by Dr. Spyropoulos and his group in JAMA just 2 weeks back. In this trial, again, they had a population of COVID patients, about 253, that have a D-dimer level of at least 4 times the upper limit of the normal, or they have a sepsis-induced coagulopathy score of 4 or more. And again, the mean age, as we can see here, is high, 66.7 years old. Comparing therapeutic dose, low molecular weight heparin to the usual care, the prophylactic or intermediate dose of low molecular weight heparin. In multi-sites, 12 academic hospital sites, and the primary outcome was a composite efficacy outcome of VTE events, arterial thromboembolism, or all-cause mortality within 30 days of randomization. In fact, if we look at the findings from this trial, what they found was that the events that happened with the therapeutic dose low molecular weight heparin were statistically significantly lower compared to the standard dose heparin. And if we look at the relative risk reduction, that was about 32% relative risk reduction. The odds ratio were 0.68. And there was, however, increased risk of bleeding, and again, almost threefold increase in the risk of the bleeding. The odds ratio were 2.8. The interesting part in this trial is that this trial included actually patients that were both immediately admitted to the ICU and patients that were non-ICU. And in fact, this trial shows very well over here that the benefit that the patient are receiving is primarily coming in those that were non-ICU patients. So almost 50% relative risk reduction in the non-ICU stratum, while the ICU stratum, there was almost no benefit at all, only 8%, and that was not even statistically significant. So we do see definitely over here, again, confirming that the benefit that we're seeing is primarily in those non-ICU patients. So now, question again.
Doctor, sorry, before, can we just address one comment before we go to this question?
Sure,
Yeah, so one of the audience, I think the question is related to multi-platform study. So the comment is that they were comparing a mix of prophylactic, intermediate versus therapeutic anticoagulation. Do you think this is like fair, or this is a proper to be done in research?
I would say it's maybe not the best approach. Again,
the Iranian study, yes, yeah.
Okay. You have to consider that these trials were done in the middle of that was affecting, and all of them were open labeled. Again, they sometimes protocols. So they tried their best to do subgroup analyses, comparing, for example, just the therapeutic dose with the immediate or therapeutic dose to the typical prophylactic dose.
Thank you.
I think because of size, maybe, yes, this is not the best design, but again, given the circumstances, I think this is the best that we were able to put our hands on.
Yeah. Yeah, actually, I had the same comment regarding the ACTION trial. They were comparing, let's say, therapeutic dose of rivaroxaban versus prophylactic dose of another medication. So maybe they would have compared the same medication, different dosing. But maybe, as you said, we were in a pandemic situation, and we need some studies to be done.
Yeah. And again, this is actually a very important point, and it's actually one of the limitations that I'm going to mention at the end of this presentation, that we still don't know exactly whether the intermediate dose has an effect and has a preference compared to the typical prophylactic standard dose. That is still to be answered. We don't have a quite definitive answer for that. So any other comments, Dr. Mona, from the audience?
No, for now, no, we can go forward with this question. But this time, this question is not included in the poll. I want the audience to write their answer in the chat.
Sure. Yeah. So I will read the question loudly. Which of the following statements is true regarding therapeutic dose anticoagulation with the low molecular weight heparin compared to the thromboprophylactic dose or the PD in medical versus ICU hospitalized patients? So no difference between both in terms of efficacy or safety outcomes in both medical and ICU. Therapeutic dose improve efficacy outcome in medical and ICU. Therapeutic dose improve efficacy outcome in medical patients only. Therapeutic dose improve efficacy outcome in ICU patients only, none of the above.
Okay. So I can see, yes, okay. You can type your answer in the chat, and I can see majority are answering the correct answer. Just to give a few seconds for the remaining participants. I think majority is giving the correct answer. Okay. So we have, okay, we have, okay, so we'll wait for a few more seconds. Okay. Okay, so I can see that, okay, majority answered C, and then some people answered B.
Okay, right.
Yeah.
So I think for those who answer C, I guess that's the correct answer that I would answer myself based on the evidence that we have so far. Again, according to these trials that we have presented so far, it seems that the efficacy outcomes are improved primarily in medical patients and not in ICU patients with the therapeutic dose, of course, of anticoagulation. Right, so we'll keep moving. So now with our case, after 2 weeks, the patient was stabilized and PCR test is negative. His breathing is becoming normal and he's ready to be discharged. The question that I have maybe for you, would you continue VTE prophylaxis post-discharge? And if yes, which agent would you use? So again, maybe that's something that you could comment on and
Sure.
talk more.
Yeah, so please, if this is also an interesting question, can you type your answers in the chat? Would you continue prophylaxis post-discharge? Okay, so we have one answer here. Okay, and if you can recommend the agent, please. If yes. Okay. Okay. So we have few answers here. I will wait just for a few seconds. I'm sorry for, I think some people, yeah, didn't see the question 5. We didn't share the poll. We asked you to answer the question in the chat because we had a problem with sharing this question in the poll. So sorry for this. Okay. Okay. So I can see interesting answers. Okay. So you can type in the chat. I can share the answers we have with Dr. Hazem. Okay, so I can see some said yes, and some recommended rivaroxaban for 6 weeks. So I can see few recommended rivaroxaban because it's easy to use and independent of kidney function. Someone recommended the low molecular weight heparin, aspirin. Okay, so I think the majority, they said yes.
Okay. And again, and this is one of those debatable, I would say, questions, and it's just a clinical decision and based on the clinical situation of the patient, the feelings from the team about how this patient is doing. And according to his risk factors, yes, we do this patient having risk factors. The D-dimer was elevated. This patient was admitted to ICU. Is diabetic, had CKD. So definitely there are risk factors that could pose VTE risk after discharge. Again, we don't have an ideal answer. So I would say it could be yes, and it could be no. Which agent would you use? Again, also for that part, I guess it's wide open. Some people may recommend rivaroxaban. Studies have shown that rivaroxaban 10 is effective. Even antiplatelets, there has been some case reports about that as well for aspirin. Of course, enoxaparin has been the standard, so that could be used if it is convenient for the patient. So I would say more or less, I mean, it's the answers that you answered is probably would be acceptable completely. But what I would like to do is just kind of, try to show you some of the recent evidence that was published regarding that part. Before we do that, of course, let me just make sure that my cursor is working. Okay. Okay. All right. So one of the things that we typically know in general about even non-COVID patients is that there is typically a risk of post-hospital VTE for those that have severe infectious disease and those that have been hospitalized for a prolonged period of time. And this risk increase typically up to 3 and even may reach up to 6 months, reaching almost 4 and 5%. This has been shown from a multitude of studies that looked at thromboprophylaxis post discharge. So this is a fact. And of course, different agents, whether it's enoxaparin or the other DOAC agents such as the apixaban in the ADOPT trial, rivaroxaban in the Magellan trial, and bitrixaban in the APEX, all of them have been shown to reduce the risk of VTE when they were used for extended thromboprophylaxis in those patients with that are acute medically ill. But of course, this was on the expense of increased risk of bleeding. So the important part is that we always have to weigh the risk versus the benefit in those patients. And by the way, for those of you who don't know, bitrixaban, although it's one of the very late DOAC agents that have been approved, actually the company itself decided to stop manufacturing the drug, so it's no longer available. So it's not just present anymore. So the main ones that we're talking about in terms of DOACs are basically the apixaban and the rivaroxaban. So the question that we're trying to find an answer for here is, do we have the same results regarding COVID patients post-discharge? So, and again, maybe we'll just show another case over here, and for both, we'll try to answer the same question. This is a 62-year-old woman diagnosed with COVID-19, and she was not admitted at all to the hospital. She had previously provoked DVT 5 years ago, diabetes and rheumatoid arthritis. These are her medications. Her vital signs are stable, but she has 3 times upper limit of the normal elevation in the D dimer. So the question again, is she at risk for VTE, and should she receive prophylaxis while she's treated at home? So that is kind of, if you would like again to share your ideas about this case, whether she's at risk and should she receive prophylaxis at home.
Okay, so you can type your answer in the chat for both questions. Do you think she's at risk for VTE, and is she eligible to receive prophylaxis, VTE prophylaxis? Okay. Okay. Okay, majority of the answers until now, yes, for both questions. She's at risk and she should receive. Which VTE score you use? Okay, so I think that's a question. Which VTE score you can use? Where's the score?
Yeah, and this is actually gonna come in a couple of slides down. So that's just I think somebody's really into the point. But I agree. I think this patient definitely is at risk for VTE. We see elevation in the D dimer. She had previous DVT event, and also the age, although maybe 65 is typically used as the cutoff for older age, but I would say that this patient still is at risk for VTE. So anyways, there is a possible benefit, of course, in COVID-19, especially at the beginning. There were case reports and case series on COVID-19 patients treated at home, showing that especially those that have risk factors, including these factors mentioned over here, they typically would benefit from thromboprophylaxis. But again, these were lower quality kind of publications, and we all know how things were at the beginning of the pandemic, and we did not have everything as standard quality in terms of the evidence. But there is definitely a possible benefit. Well,
So, sorry, Dr. Hazem,
yes,
just a
Dr. Mohammed.
comment regarding the last case. So, I think it's something related to VTE versus bleeding risk. So, the comment is that the patient may be at bleeding risk due to naproxen.
Yes.
Yeah.
Yes, that's very, very true. So that, of course, has to be considered. I would totally agree with that. Let's see what's the evidence. And this trial is the active 4B trial. This trial was published less than a week ago. And again, and I was, like even going without finding this trial, but then, I found that it was published. So when I looked at the website and was able to pull it out, I said, okay, well, that's a good answer that we have over here. So this trial was basically trying to answer this question, that among asymptomatic but clinically stable outpatient with COVID-19, if we add antithrombotic therapy compared to placebo, would that reduce major cardiopulmonary adverse outcomes over a 45-day treatment period? So what they did was they tried to recruit patients that don't have typically any risk factors. They could have or not any risk factors. That was not among the inclusion criteria. And maybe this is one of the drawbacks in this trial. As we can see, the median age is low, 54 years. And this was done primarily in the United States. And they had 4 arms. So they had, compared to placebo, they looked at aspirin, prophylactic apixaban, which was the low dose, 2.5 milligram twice daily, or therapeutic apixaban, which was 5 milligram twice daily, all of this for a duration of 45. Their findings was very, to me, it was very surprising. What they found is that they had to stop this trial prematurely because of the low incidence of VTE events. So although all these reports that we have been hearing at the beginning of the pandemic about how really there is a risk of VTE for patients while they're at home, treated at home, what this trial found is that the number of incident events were very, very, very low. So as we can see in the 4 different groups, they only had like 1 case or 2 cases at most. So of course, all of them almost had the same percentage, and there were no ability to detect any difference between any arm and the placebo. So the conclusion was that the data really does not support the use of aspirin or apixaban, whether in the form of a prophylactic dose or in the form of a treatment dose. I would say that this conclusion is inconclusive because this was prematurely stopped. So you don't really have a strong evidence that there is no difference. What you have is that low number of events that is not powered enough to find out whether there is a difference or not. And maybe this was one of the issues that the population they recruited did not really have any risk factors. So maybe majority of them really were low risk, and that's why we have low number of events. That's my intake on it. I would say that regarding that part, the answer is still not definitive. We're still awaiting results from other ongoing clinical trials. That is a Prevent HD trial. This is a trial that you maybe want to be looking for. That is comparing rivaroxaban 10 milligram versus placebo in patients with at least 1 risk factor. Regarding the guidelines and what they recommend in terms of post-hospital VTE prophylaxis for COVID patients, again, it's debatable. The AC forum would say that it's not for all patients, and if you use it, try to follow the clinical trial inclusion criteria in terms of giving it only to patients that are at risk and considering, of course, the bleeding risk. Chest, again, almost the same answer. ISTH, maybe the one that gives a little bit more definitive answer. They recommend it for those that are high risk for VTE and low risk for bleeding, and considering the risk factors as older age, ICU stay, cancer, having prior VTE events, elevation in D-dimer, and they recommend to use the improved score. So again, regarding one of the colleagues who was asking about what score would you use, I would say either the improve or the improved D. The improved D is similar to the improve, but includes the D-dimer level as another discriminating factor that would give us a better resolution regarding those patients that are at risk. So this is the improved D score, and I would say that for patients that have a score of 7 or more, this would be considered to be a high risk for VTE incidence. So, Dr. Mona, before I go into the conclusion, do we have any questions or comments from the audience?
Yeah, sure. The comment is that about the score, because none is validated for COVID, but I think we can still maybe use them because we have no other option.
And again, yeah, that would be great if we have something that is
Yeah.
validated in COVID, but yeah, unfortunately we don't.
Yes, we have also, we should better design one, of course. The comment also from the audience, we should better design one. Of course, this would be great if we can
Great
do so.
research study, yeah, if you if you into it, yeah, that would be nice.
Yes. So there is also one comment regarding obesity and the VTE risk. So we know that in the anticoagulation, we do sometimes have different dosing or different monitoring in patients who are obese. So, okay. So in case of COVID, do we have any guidance in terms of dosing, or do we follow the same approach for patients who don't have COVID?
And again, this is according to the best of my readings, and I think the most comprehensive guideline that I've read in that perspective was the ISTH, and according to the recommendation, you would use the same. I don't think this was specifically tailored towards COVID, but in general now, AC Forum as well as ISTH, according to the accumulating evidence regarding DOACs in morbidly obese population, uh, it's been almost now confirmed that the same efficacy is provided with the DOAC agents with the same dose, even in morbidly obese population.
Perfect. And we have another interesting question. Is there any evidence if patients who already on aspirin or P2 Y12 inhibitor were they at risk of thromboembolism events with COVID?
Mhm.
So
That one, I don't know. I would just say that I don't know. I have not come across that. I know there is a lot also that talks about the use of antiplatelets. Even many of these trials, you would find in their baseline demographics they were trying to look at the difference in the antiplatelet use versus no antiplatelet use, and then were no difference. And again, of course, I don't think any of these trials were powered enough to detect such difference. But uh, I think the Active 4B that I just presented was trying to answer the question regarding the aspirin. But I know that there are some other trials, I forgot the name, but I think there are other trials as well that are still conducted. They're trying to answer the question about antiplatelets.
Okay, and speaking about the scores we use for VTE, so when we want to just like measure the risk of bleeding versus VTE, can we use any bleeding score like has bled? I know it's not for COVID,
Yes.
but do you prefer, from your experience, to take into consideration patient risk factor rather than going with a scale?
I think, yeah, especially if you don't have something that is validated, it's better to take it from clinical perspective. And again, the risk factors for bleeding are again very well known, or at least we know what typically may increase the risk of the bleeding. So whether this patient had recent bleeding events or any kind of trauma or open surgery, we know some factors like advanced age, especially those frail patients above 65 and 75, they are typically more prone to bleeding using medication that would induce bleeding as antiplatelets or NSAIDs or corticosteroids. So all of these definitely are important factors. Patient with GERD, peptic ulcer disease. So I would definitely consider all of them. Hypertensive that are uncontrolled. So definitely I would consider all of them. And all of them are as you mentioned, in some scores such as has bled, but I wouldn't just take it as strictly as that.
Yeah, and maybe speaking about the bleeding, we have question of regarding bleeding management in COVID patients who are on VTE prophylaxis. So do we follow the same approach, the same management in terms of bleeding management or reversal?
Again, I would say so. I don't have a definitive answer for that, and I would be happy to listen to any of you who would have experience from their practice and would like to share it. I would be really happy to hear their opinion, but I would say it's probably the same.
Yeah, so one from the audience commented, yeah, this depends on the bleeding. If it's minor, yeah, of course we do nothing. Yeah. Yeah, I think it's similar management. If it's moderate, to try to compress. Okay. So this is the answer from the audience. And it's measure, do the needful. Yeah. So I think it's we follow the same approach in patients with no COVID. Okay, so if you have further questions, care-free reversal of anticoagulation. Yeah. So if you have any further questions, you can type in your questions in the chat, or if you have anything to add from your clinical experience or from your clinical perspective, you are most welcome to add. Doctor, I have comment, maybe you have noticed that the and therapeutic anticoagulation was more effective in stable patients.
Yeah.
Do you think we have a reason behind this?
That's a great question, Dr. Mona. So, and again, when we think about it deeply, if you think about those patients that come to us already complicated with requiring ICU level care, probably the damage has already happened in those.
Yeah.
So microthrombus has been formed. It's been there for a while. They may be already, it's very hard to reverse it. It's almost irreversible. I think this is the reason why ICU level patients did not benefit from the therapeutic dose anticoagulation. While if we catch them while they are still stable, they are still on the floor in the medical ward, we can still benefit from the therapeutic level anticoagulation. And that's why I mentioned that the recommendation is basically if you start them on therapeutic dose anticoagulation in the medical ward, even if they are transferred to the ICU, continue with therapeutic dose, because I think it will be unethical, if you will, to do it this way, especially that the trials that showed the evidence were not designed that way. It were for those that already come to the ICU, already have that major damage with the DIC and SIC and overt coagulopathy, if you will. So that's my intake on it, and to the best of my opinion, many expert opinions as well, they would say the same.
Okay, perfect. And we have here another different question about thrombolysis or mild lysis by argatroban.
Okay.
Yeah. So
So what the
yeah,
question is whether we should, or it's recommended to use thrombolysis or mild lysis with agent like argatroban. I would, I don't have a definitive answer. I did not come across any study per se that looked into that. Again, argatroban is similar to the heparin, so it's an anticoagulant. I would say that there is no harm to use it as an alternative, if you will, especially in those patients that have maybe, like if they like you don't want to use unfractionated heparin, or you want to use something that has better potency. Argatroban could be an agent to be used, but I'm not really sure if I came across evidence specifically towards argatroban.
Okay. And doctor, this is like from your experience with DUAC. So do you see a future for, because we see that we have positive outcome with rivaroxaban. So do you see like also positive outcomes with other DUACs in terms of COVID, taking into consideration the pathophysiology and the knowledge we have until now with COVID?
So again, that's an interesting part. So when it comes to the use in post-discharge, I think maybe there is a benefit for those stable patients. or for those patients that have not been hospitalized. But again, we're awaiting results. As I mentioned, the Prevent HD is one of those trials that we're awaiting the results for, especially with the ease of use of the DOACs, the ease of the dosing, no requirement for injections. And again, if we even compare them to the warfarin, we all know the issues with warfarin. So definitely they would have a role in there. But if we start to think about maybe the trials that we have shown where rivaroxaban, I think that was the ACTION trial, where the rivaroxaban therapeutic dose did not show an effect, while actually we have seen an effect with the low molecular weight heparin therapeutic dose in medically ill patients. I think this is telling us that possibly heparin products, they do have pleiotropic effects. And there has been also a lot lately in the literature that talks about anti-inflammatory effects as well as antiviral effects of heparins and how that may be adding into their benefit for COVID patients. So if we talk specifically about COVID patients that are hospitalized, I wouldn't recommend the use of the WAC. Maybe post-discharge, or maybe for those that are stable, if it is later on proven to be effective, that could be the agent of choice for me. But in general, if hospitalized, I would definitely not go with them.
Okay, so doctor, let's say if we have a patient, sorry?
I said that would not be my first choice for hospital use.
Yeah, and here we have a comment also from the audience that DUACs should be avoided in all IC patients because we don't know if they are resorbed. Moreover, the excretion may be altered and the measurements of blood levels are not done in Qatar.
That and also if we think about COVID patients, we have all seen all the different agents that have been used, antivirals, remdesivir, corticosteroids. So again, there could be possible potential interactions that even we know or we don't know about. And again, we don't have an easy way to monitor those agents and measure the level. So I wouldn't recommend using them at all.
So doctor, let's say if we have a patient who has AFib already on DUAC and admitted to the hospital with COVID, so would you recommend now to stop or switch at least DUAC to other anticoagulant?
I would, and again, I don't know what's the standard of practice that has been done over here at Hamad, but I would say that this would be a cautious action to switch those patients to heparin products while they're in the hospital.
Maybe if we have some people,
they could share what's been going on in the ICU or on the medical ward.
And even maybe in terms of monitoring, so maybe in the beginning you have mentioned about the inflammatory biomarkers.
Yes.
So
and all of that, could affect a lot what's happening with the use of the DOAC and could alter the level.
So one of the answer is in terms of switching DUAC to other anticoagulant, this could be done depending on the severity of the case. So if the COVID keeps mild, you could keep DUACs. If not, they go for low molecular weight heparin.
Okay, makes sense. So only for mild cases, they may keep the
mild
patient
cases,
DUACs. That makes sense.
Yeah, the issue like still with COVID, we don't have confirmed maybe answers for many questions.
Yeah. Well, luckily, I think that now the pandemic is subsiding, which is great for everyone. But I think there are a lot of lessons learned from these trials, and that's why I thought to share that topic because it's interesting and a lot of evidence is coming just lately, only in the past 3 months.
And okay, I think so. If you have further questions from the audience before we go with the take-home messages.
I have basically just 2 slides on messages or conclusions as well as limitations. And again, I'll be happy to receive any comments from the audience.
Sure. Yeah, we can go with these take-home messages and then until we receive further questions.
Sure. So again, we learned that treating medically stable hospitalized COVID patients with therapeutic dose heparin for prophylaxis help improve survival. That has been shown in the trials. However, this should likely continue even if the patients get admitted to the ICU, as I was just discussing right now with Dr. Mona. And again, apparently, yes, D-dimer is important, but we should not guide the treatment in terms of the D-dimer level. So, for example, just only those patients that have very high D-dimer level will give them therapeutic dose, and those that have low D-dimer level, we give them prophylaxis. I don't think the trials have shown that. I guess everybody will still be benefiting, especially if they have low bleeding risk. In terms of those patients that already are coming with complications and they would be ICU COVID patients, we better treat them with prophylactic heparin dosing that will yield better outcomes with less bleeding. And the role of intermediate dose anticoagulation in prophylaxis in non-ICU still remains to be answered. We don't have an exact answer for that yet. For discharged COVID patients and patients treated at home, they should not receive prophylactic anticoagulation unless really they are at high risk for VTE, as well as, of course, low bleeding risk or acceptable bleeding risk. Limitations from these trials, of course, there are plenty of limitations. I'll just name a few. The open label design that we have from all these trials, this, of course, adds potential for ascertainment bias. And the absence of protocol-specified screening for venous thrombosis. How would you screen for that? That was not always unified. There is no exact protocol. It was left at the discretion of the clinicians. And again, the pandemic. Pandemic itself, it had a lot of dynamics. It had a lot of cycles. There were ups and downs, changes in medications and management, even in the virus itself. We know with all these different the Delta virus and new virus and so on. So even like the aggressiveness and the severity has been changing, and the medications that we have been using have been changing. So all of that could have played the role into the limitation that we have seen from these trials. So that's basically it. I would like to, thank you so much for your insightful comments and questions. And again, apologies if I couldn't answer all the questions, but that's what I believe. I want to learn from you as you have. I hope that you have learned from me as well in this presentation.
So thank you so much, Dr. Hazem, for this informative presentation. I know it's a debatable topic. It was quite hard to answer some questions, but I know because still we have nothing confirmed yet. But for sure, it was very informative. And maybe this is like still a gray area for majority of us. So now I think we have a more clear vision about our plan in terms of anticoagulation in patients who are hospitalized with COVID. So I would like to thank you, Dr. Hazem, again. Thank you so much for the audience, for your participation, for being active in this session. And thanks for our viewers on YouTube. I would like to remind you that to claim your CBD points, please just do the CBD survey after the session. And you can either access the survey from the website, or you will receive an email after the session. And please, you are encouraged to register in the upcoming events. Thank you again so much for your time, and thank you, Dr. Hazem, as well.
Thank you, Dr. Mona.
Thank you.
Have a great night, everyone.
Thank you.